Very nice.
Yeah. Assalamu alaikum. Good morning, everyone. So my task will be more difficult, actually, is to convince everyone that cardiologist has a role in managing the pulmonary embolism patients. So this is my disclosure. So we know, as mentioned before, that pulmonary embolism is a leading cause of mortality all over the world, and the high-risk patient represent 5% of the pulmonary embolism population, but have 60% mortality. Then now the intermediate risk represent 25 to 40. The mortality is ranging between 2 and 21 at 3 months. And up to 50% of surviving patients exhibit some shortness of breath, at least class 2, at 6 months to 3 years on follow-up. Now, the challenge of the pulmonary embolism that a lot of specialties and a lot of team are involved. It is maybe the pulmonary, the critical care, the emergency doctors, radiologists and cardiologists, hematology, oncology, interventional radiologists, maybe cardiac surgeon and internal medicine, expanding to the clinical pharmacist and nursing team. All of them, they have role in managing these patients. To meet them and to have the full decision among these teams is really difficult. And to coordinate the management between these teams is more challenging. Now, the different management options, whether anticoagulation, IVC filter, systemic thrombolysis, or catheter-based, whether thrombolysis or embolectomy, ECMO and maybe surgical embolectomy also represent another challenge to standardize the management among these patients. Now, in some studies that, as mentioned by Dr. Ali, that only 2% of patients with PE and 9% of the patient of massive PE received thrombolysis. So also that represents another challenge. Another challenge is the logistics. You need to coordinate between the IR, the thrombolysis, ICU, echo, Doppler, and CT, and also the ECMO team. So these make the management of these patients more complex. Sometimes there will be delay in the management of this patient. So this is the idea where it comes, the importance of pulmonary embolism response team is to coordinate and facilitate the care of these patients. So it is usually consistent of multidisciplinary team, including specialists from pulmonology, ICU, cardiology, interventional radiologist and cardiac surgery, and sometimes the ER, which is in some study showed that 40% of referral of pulmonary embolism came from emergency department. The activation of PERT facilitates rapid risk stratification and management, and it has also outcome effect on the outcome of these patients. This is one of the early studies from Massachusetts General Hospital, where it showed there is no difference in major bleeding or mortality between pre and post PERT application, but it has effect on the utilization of catheter-based therapy. Another study showed improvement in survival and mortality. This came from Cleveland Clinic, where it reduced the mortality, especially among the high-risk patients, and also reduced the length of stay compared to the pre-PERT application. Another study showed there is increase in the use of thrombolytic and catheter-based strategy. However, it was not statistically different. There was a trend toward survival benefits among high-risk patients, high-risk pulmonary embolism patients, but again, it was not statistically significant. Now, how to start this PERT program? From our experience, we started with gathering the team. You have to collect people who are enthusiastic about the idea. We choose these 6 members, pulmonary, ICU, ER, interventional radiologist, cardiologist, and the clinical pharmacist. And then we start to write the protocol. You have to define the criteria for the high risk and intermediate risk. You have to define the rules of every team, because it is important before the start, you know, every team what's their rule, and you have to identify the point of referral. We decided that all patients will be referred to the pulmonary team. There is a PERT fellow, 24 hours a day, 7 days a week. Who will receive all the referral from all the hospital, including the ER, inpatient, anywhere in the hospital, and he will assess the patient, and he will discuss with the PERT consultant on call, who is the pulmonary consultant, and he will decide whether to activate the PERT team or not. And then after writing the protocol, completing the protocol, we move to the next difficult step, which is convincing the people to get involved in this task. It is difficult because they consider this as an extra work, and some people, they consider it as an overlap between them and between their work and the PERT team. Like the ICU consultant, they will tell you, we are dealing with the shock patient, so we have our decision, which is sometimes not in agreement with the PERT team decision. So you have to keep them online. So we decided to involve them during the discussion. A major problem, it is not that the PERT work is not compensated. This is not only in our area, but it is internationally known that it is not compensated. And the more difficult task is that to convince the people that this is part of your field and not away. You are involved in this, because the most common answer that it is not my field. This is a pulmonary team or the ICU team. Now, what we did, we met every department. We did the meetings, awareness, lecture presentation with them, trying to convince them. In the beginning, to tell you the truth, there were not much of enthusiasm about the idea, but later on, the people start to get involved gradually. Now, this is the actual word. Once you receive the call, the PERT activated, we use the WhatsApp group to alert the people, and then we'll join everyone through the Zoom meeting at any time of the day. We made the discussion in the Zoom meeting very concise, very short. We don't want to prolong the discussion, and we have to take a decision. As we have to give the rules to activate the echo, to alert the interventional radiologist, and to, also if ECMO needed, we have to call the cardiac surgeon to activate the ECMO team. For the echo will make a big difference in the decision, because you can see that it differentiates between the low risk, intermediate, and the high risk patients. So I'm thankful to all echo team who are really ready to do the echo at any time of the day, including late nights. Then this is some of our data. We started our program in January 2024, and we have 6-month outcome. Our target was 14% mortality, and you can see that we reached average of 10%, and then our incidence of bleeding was really low, with high compliance with the clinical practice guideline. I will present two cases where I believe that cardiologists made a big rule and the echo changed the management of those patients. So 52-year-old male with ischemic heart disease post-PCI to LAD in 2015 and 2023 with HFrEF, smoker, diabetic, admitted as a case of inferior STEMI, had cardiac arrest, intra-aortic balloon pump was inserted. He had coronary angio, successful PCI to RCA. He stayed in the hospital for a period of time because he had ischemic insult to the brain. And on the 5th of July, he had BA arrest where he need ECMO and intra-aortic balloon pump again. And this is the echo. We started with echo. So the echoes was the alert for us to activate the PERT protocol because it showed that the RV is dilated with positive McConnell sign. And the CT showed bilateral massive pulmonary embolism. And the patient underwent successful catheter-based embolectomy. And that's the result, and that was the thrombus aspirated from that patient. So another case where 59-year-old male medically free presented to ER with left leg swelling for 2 weeks. And an exam was, blood pressure was stable, but he was tachycardic and he was requiring high flow oxygen. And on the examination, he had left leg with calf muscle tenderness and swollen leg. And in the CT, he had bilateral pulmonary embolism, massive pulmonary embolism. It was reported by the radiologist. So the echo showed the RV is dilated with positive McConnell sign, but there was an RV thrombus. It's not only in the RV, but it is also in the RVOT. Sorry, it's not playing the other video, but you can see that in the RVOT that there is a thrombus. So, 2 slides.
Give us 2 minutes, please.
Only 2 slides remaining. Yeah. So now what's the best option? That blood pressure was stable, but he's tachycardic and he was requiring high oxygen. But also there is RV thrombus and RVOT thrombus. So the decision was if we give a thrombolysis, he will shower more thrombi to the lungs and he will deteriorate more. You cannot use the catheter-based intervention because simply you will dislodge this clot. So the decision was to activate, to call the surgeon for surgical embolectomy. And this is intraoperative TE. In the left, this is in the beginning, and after a few minutes, that's what happened. RV ballooned, and you can see that almost it's not moving. Patient arrested, and that was the cardiac massage by the surgeon. So he was connected to the bypass and they did successful embolectomy, surgical embolectomy. Just 1
minute, please.
Yeah. And that's his echo after 3 months. He survived that event. He was discharged, and you can see the RV is back to normal, almost. So PERT is a collaborative multidisciplinary team approach for treatment of intermediate to high risk. It coordinates, facilitates, and keeping a standard treatment of the management of the high risk patient, aiming to improve the outcome and survival. It needs dedication and collaboration of all the team, and protocol pathway should be clear and evidence-based as much as you can. However, clinical decision and team decision is essential. Again, I would like to thank my ECHO team who are working the whole year, they were working great to support these patients. Thank you.